Good afternoon, everyone. Pediatric Center of Excellence in HIV Care at Kalavati Saran Children's Hospital, New Delhi, welcomes all the participants for today's RDLS session. Today's topic is determinants of first-line ART regimen in CLHIV. We'll be covering it through case scenarios. We have with us today Dr. Harshita ma'am. Dr. Harshita Gosainwal ma'am is currently working as the medical officer with the ART centers at KSCH, New Delhi. We welcome you, ma'am, for today's session and request you to start the session.
Thank you so much, Shweta. So, good afternoon, everybody. Today, I'll be doing a session that is RDLS on determinants of first-line ART regimen in CLHIV and discussing some of the case scenarios. So, what are the objectives of today's session is we'll discuss, according to the national guidelines on ART initiation in CLHIV, that is, what are the goals of ART in children living with HIV, how do we evaluate a child before a ART initiation? What are the first-line ART regimens in CLHIV and ART in TB-HIV co-infected children? So, what are the goals of ART in children living with HIV? Main goals are you need to prolong after like, if you start ART with CLHIV, our goal is to prolong the survival of the CLHIV. We'll be able to reduce the morbidity and improve the quality of life. We'll be able to preserve, enhance, or reinstate the immune system and therefore reduce opportunistic infection a CLHIV can have. And obviously, it is to suppress HIV replication. And most important is we need to promote the optimal growth and development of the child. So now, what are the steps in preparing a child for ART? First of all, we need to identify a caregiver. सबसे पहले हमें केयर गिवर को ढूंढना है, चाहे वो उसकी कोई भी फैमिली मेंबर हो। लाइक कोई भी बच्चा आता है आपके पास तो उसका केयर गिवर फर्स्ट केयर गिवर इफ मदर इज अलाइव तो मदर फादर पेरेंट्स हैं तो obviously mother is the first person who is a caregiver and usually the parents maybe the maybe other family members can be a caregiver. First you need to identify the primary caregiver. We may need to identify a backup caregiver if a primary caregiver is a CLHIV. Then you need to assess the child. What are the assessment we all know? We need to do the baseline clinical and lab assessment. We need to assess for the seriously ill child. Then we need to screen for the advanced HIV disease, which we learn in further slides. We need to evaluate, diagnose, and management of the opportunistic infection, including tuberculosis, cryptococcal meningitis, PCP, etc. We need to have a baseline psychosocial assessment of the caregiver and the child also. Now, we need to do the initiation of 4-trimoxazole, that is Ceptran therapy or 4-trimoxazole preventive therapy. And then we need to prepare the child and also the caregiver for lifelong ART. And then we need to stabilization of the patient before ART initiation. It is important to prevent IRIS, that is immune reconstitution inflammatory syndrome. So before starting a ART in CLHIV, you need to follow these steps. First is you need to identify a caregiver, that can be parents or maybe other family members, and then you need to have a backup caregiver. Like if a primary caregiver is not available, the secondary caregiver or the backup caregiver should also know how to give ART to the child. Then you need to assess the child, like clinical lab assessment. You need to screen for advanced HIV disease. Then you need to manage all the opportunistic infection. Then you need to have a psychosocial assessment of the child. You need to start the CPT therapy. You need to prepare the child and caregiver for lifelong ART. And you need to stabilize the patient before ART initiation as to prevent IRC. So, this is the case scenario one we can see. Let's assume that Miss A, a newly diagnosed HIV infected child of age 2 years, she has persistent oral thrush. She has achieved normal developmental milestone, but has failed to gain weight and height as expected. The weight is 6 kgs, which is less than -3 Z score. Height is 72 centimeters, and this Z score is also -3. The CD4 count is 18% and 500 cells. Hemoglobin is 7 gram per deciliter. So the first question arises, what needs to be done before the ART initiation? And the second question is, what is the clinical stage of the child? And the last question is the CBT indicated in this child or not? So I would like some few to answer these questions if anybody can. Then I'm
Request.
audible, huh?
Yeah, you're audible, ma'am. Requesting participants to please put their responses in the chat box.
Works, or they can unmute their mic if they want.
We'll give mic access, ma'am. Kiran sir, I'm giving mic access to all. Yeah, mic access has been given to all the participants. You can unmute and answer, or you can put your responses in the chat box.
Any answers in the chat box, Papa?
No, no answers in the chat box, ma'am.
Okay, so then I'll go again ahead with the slides. Okay.
Yeah.
So the what needs to be done before ART initiation, as we have all discussed, we will discuss on this also. We'll do a head-to-toe physical examination. We need to have the growth assessment that is weight and height. Length we take in the children who are less than 2 years of age, and the children who are more than 2 years of age, we take the height of the child. Then we need to have the developmental assessment, and we need to screen the child for signs of serious illness and advanced HIV disease. We need to have baseline investigations, including the CD4 count and the percentage. We need to screen and manage all the opportunistic infection, including forest screening of the TB. Everybody knows forest screening of the TB symptom, that is cough, fever, night sweats, or any history of TB contact. We need to do the preparedness counseling after identification of the caregiver. PPD needs to be initiated and checked for its adherence in initial visits. Management of severe malnutrition is essential and it may need hospital admission or advanced services. So what do we do in the clinical assessment? We do the head-to-toe physical examination. We do the growth assessment, as we have said, weight and height of the child. We do the developmental assessment. What are the signs of poor nutritional status is? Patient can come to you with the complaints of lethargy, oral thrush or sores, difficulty in swallowing, or can be fever, anemia, edema, or swelling of the limbs. And then there are signs of vitamin deficiency, that is glossitis. Patient can have vitamin B12 deficiency, or you can have vitamin A deficiency that you can see like bitoid spots in the patient. You can see the muscle wasting and other features of opportunistic infection. In the figure, you can see there is wasting. In the images, you can see the child. There are oral thrushes, which you can see in the mouth, tongue and mouth of the child. You can see the edema in the patient in the third picture. Okay. So, what is the definition of advanced HIV disease? What do you mean by advanced HIV disease? Is when for the adults, adolescents, and children who are older than 5 years of age, advanced HIV disease is defined as CD4 cell count less than 200 cells or WHO staging 3 or 4 event. It includes both ART naive individual and those interrupt treatment and return to the care that are lost to follow-up patient. All children younger than 5 years of age who are not already receiving ART and clinically stable with HIV are considered as having advanced HIV disease. What are the concerns about advanced disease in HIV? That is increased morbidity and mortality rates, highest, especially during the first 4 weeks of ART. And then there is an increased mortality risk persistence even after ART initiation. There is an increased risk of HIV transmission. So there is intensified adherent support at the time of diagnosis, ART initiation, and during the episodes of acute illness benefits people with advanced HIV disease. So this is the important point. You need to have a enhanced adherence counseling or an intensified adherence support at the time of diagnosis, ART initiation, and during the follow-up visit, and plus the acute illness of the children. And so, what are the screening of CLHIV less than 5 years for advanced HIV disease? So, what is the role of a medical officer? A medical officer need to assess for the presence of any danger signs and serious illnesses. And you need to screen for the presence of severe acute malnutrition. You need to screen and treat the opportunistic infections like tuberculosis, meningitis, rapid CPT initiation in the new cases, TPT or TB preventive therapy or isoniazid preventive therapy or 1 HP which is in the absence of active TB. Then you have to have rapid ART initiation in the new cases. You need to have intensive counseling in the follow-up. So for this is algorithm you must have seen in the guidelines. So whenever a child who's less than 5 years of age with newly diagnosed HIV infection comes to you on your ART center, first thing the care coordinator and nurse will do is they will ask the 4S TB screening symptoms that we all know, that is cough, fever, poor weight gain, or weight loss in adults, reported weight loss, history of any contact with tuberculosis. If it is present, the medical officer needs to investigate for TB. The investigation you need to send is X-ray or induced sputum or a GA, that is gastric lamar for lab testing, TB lab testing. TB lab you can send if CD4 count is less than 200 cells or WHO clinical stages 3 or 4. Right now, TB lab is not in our program. So then, after the patient goes to the care coordinator and nurse, the patient will come to the medical officer. The medical officer will check for the danger signs, like if the child is lethargic, not able to drink or breastfeed, there's vomiting, convulsions, the child is unconscious, there is a stridor in the calm. So you need to look for the following signs, that is fast breathing, chest drawing, sunken eyes, skin pinch which retracts slowly. You need to check for the fever if the temperature is more than 35 degrees Celsius. You need to check for stiff neck or bulging anterior continental. Any of the danger signs are there, you need to refer the patient for further management of acute conditions, including hospitalization and referral to the higher ART center. And if these danger signs are not there, so the medical officer, in consultation with the pediatrician, we need to check for the SAM or severe acute malnutrition and any of the following symptoms. Like there's the presence of medical complication, any danger signs. Is there any severe dehydration, pneumonia with chest and drawing? If the child is not able to finish ready to use therapeutic food, that is RUTF, or breastfeeding problem. So you will refer the patient if these are there, these signs and symptoms are there. You need to refer the child for further management to the higher center or hospitalization may require. If these signs and symptoms of SAM or any danger signs are not there, the medical officer will decide if the child is less than 5 years with any danger signs and or severe illness like pneumonia, active TB, diarrhea, dehydration, SAM, meningitis, or WHO clinical stage 3 or 4, if the CD4 count is less than 200 or low CD4 percentage, and if the viral load is unsuppressed, that the viral load copies are more than 1000 copies per ml, if these are there, then the patient goes to the advanced disease management package. In the package, you can see there is initiation of the security prophylaxis at earliest, treatment for the opportunistic infection, there is preparedness counseling of child and caregiver on ART and nutrition. Main important point is rapid initiation at the earliest. PPT or the IPT for children above of age as per the national guidelines. Then you need to immunize the child as per the national immunization schedule, and you need to have intensive follow-up of the patient. If these all, this is for the advanced disease management package. If patient does not have the above symptoms and signs which I have told you can go for a standard package of care. That is, you need to treat and sterilize after the opportunistic infection and SAM. You need to again initiate the CPT therapy or the Satram therapy. You need to do the preparedness counseling of the child and caregiver on the ART and the nutrition, and you need to counsel about the lifelong ART the child has to treat. You need to do the ART initiation before discharge. You need to have PPT or IPT for children above 1 year of age as per the national guidelines. Again, you need to immunize the child as per the national immunization schedule, and you need to have the intensive follow. So these are the, I'm so sorry. So these are the main screening you have to do if the child is following advanced HIV disease. And how will you evaluate a child for TB and CLHIV? If any HIV infected child comes, you need to do the intensified TB case finding. As I told you in previous slide, you ask for the 4S symptoms. From the care coordinator or a nurse will ask about the 4S symptoms. If those symptoms come out to be positive, the medical officer will investigate the child for TB. So if we find the child is having a presumptive TB, if the child is having a presumptive pulmonary TB, you need to send the NAT or two smears for AFP and the chest X-ray. If the patient is having presumptive extrapulmonary TB like abdominal cough or a cervical lymphadenopathy or TBM, you need to send the NAT, the culture or smear positive specimen from the extrapulmonary site. Then you need to then you need to send the cytology or histopathological examination from the extrapulmonary side. You have to have X-ray, chest, and other relevant imaging just like for extrapulmonary TB. So in the presumptive pulmonary TB, if the NAT or the smear or the CT-NAT comes out to be positive, the child is considered as bacteriological positive TB. The smear and the NAT test is negative, that is CT-NAT is negative. When X-ray is suggestive of TB, the child is labeled as clinically diagnosed TB. And if the smear, that is AFB, and the CB-NAT is negative, plus the X-ray is also negative for TB, the child is non considered to be having TB. And for the extrapulmonary TB, if the smear culture comes out to be any of the if it comes out to be positive, the child is considered same as extrapulmonary TB. So these are the flow charts we discussed in previous slide also, that how will you do for TB evaluation in the children. I would like to focus on how do we do a pediatric evaluation if the pediatric lymph node tuberculosis, how will you assess that? When will you suspect the child is having a lymph node tuberculosis? If there is a persistent enlargement of a lymph node for more than 2 weeks in one or more areas in cervical or axillary or any inguinal region, and the size should be more than 2 centimeter, or there should be matted lymph nodes, plus or minus the chronic sinuses. It should be with or without associated systemic symptoms, that is fever, poor appetite, cough, weight loss, with no evidence of recent or the skin lesions of the draining area, cold abscess, chronically discharging sinus over neck, axilla, or groin. TB is unlikely if the lymph nodes are small, that is less than 2 centimeter, and are persisting for a long time, that is months to years without any systemic symptoms. So how will you investigate? As we have said, there are essential investigation that you need to do, and there are desirable investigation that should be done. For the essential, the lymph node aspirates need to be sent for NAT testing, that is for CB-NAT testing, and we should also send sample for NGID culture, particularly if you see that the patient is at risk of having drug-resistant TB. And you need to send the lymph node aspirate for AFB2. What are the desirable investigations you can do? You can have a lymph node cytopathology if NAT and smear are negative. You can have the lymph node biopsy, that can be a core or external biopsy. Chest X-ray should be particularly done if FNSC is not possible. Hemogram, that is CBC with peripheral smear and cytopath of that lymph node. So we can see if the peripheral lymph node is in one or more sites, the investigations which you need to be done is X-ray. If the chest X-ray is abnormal, you need to get the sputum or the reduced sputum samples. And if the TB is detected in the sputum or reduced sputum or GA sample, you label the child as you will give the child will you will label the child as bacteriologically TB positive, and you will give the regime according to the test, that if the child is drug sensitive, that is rifampicin sensitive, the child is having an MDR TB. But the lymph node, you need to look for the matted cold abscess or sinuses. As we have said, we need to aspirate from that side. We need to do the lab testing, AFB and cytopathology. And we need to send an MGIT to look for drug resistant TB. If that comes out to be positive, we treat according to the testing. That if the CB-NAT test, the sample is coming out to be RIP sensitive, we'll follow the drug sensitive TB guidelines. If the sample is coming, the RIP resistant is coming, or there is some resistance coming, we can follow the guidelines according to the drug resistant TB. So, which CLHIV needs to be assessed by a pediatrician? In this, you can see desirably that all the new diagnosed CLHIV to be comprehensively assessed by a pediatrician conversant with the HIV care. So, main important point is कोई भी बच्चा CLHIV आपके पास आता है, आपको एक बार उसको pediatrician को रिव्यू करवाना ही करवाना है. CLHIV will specially need a pediatric referral If there is malnutrition, poor weight gain, or growth failure, if there is any developmental delay, and there is loss of previously attained milestone, there are associated systemic symptoms, the child is seriously ill, or there is any presence of any systemic opportunistic infection, that is TB, typically meningitis, or any PCV infection. So we'll continue with the case. So the second question was, what is the clinical stage of the child? As we had seen in the previous slides, that the weight was less than -3 z-score, the height was also -3 z-score. We will label the child as clinical stage 4, that is severe malnutrition. Child should be evaluated by the pediatrician. Is CPD indicated in this child? Yes, CPD is indicated in this child as the child is less than 5 years, irrespective of our clinical stage in CD4 count. And everybody knows we give the syrup septram and according to the weight, which is coming about to be 5 ml once a day. So when do we do the rapid ART initiation in CLHIV? Rapid initiation of ART is advised in CLHIV after appropriate preparedness counseling has been done. To be initiated regardless of age, CD4 count, and WHO clinical stage. However, ART is a non-emergency intervention. Treatment preparedness and management of OIs is given priority over ART. Okay, and seriously ill and hospitalized children should be sterilized before ART initiation. So in CLHIV, the point to be noted is ART is a non-emergency intervention. First, you need to do the preparedness of the caregiver and the child, and you need to manage the opportunistic infection over ART initiation. So, what are the pediatric ART regimes? The key considerations are Pacivir is the first preferred NRTI for ART initiation for CLHIV, as everybody knows. Lamivudine is the second NRTI component for all the patients. CLHIV less than 20 kg will be initiated on dolutegravir 10 mg base regime. Everybody know about that. For the children with weight more than 220 kg, dolutegravir 50 mg film coated is recommended as a preferred third drug. For all the children who are more than 10 years of age and the weight band is more than 30, tenofovir is preferred for first NRTI drug for ART initiation in children. So what are the ART regime in CLHIV we have? Dolutegravir 10 mg is a disposable tablet advised in CLHIV less than 20 kg. Dolutegravir 50 mg film coated tablet is used in CLHIV weight more than 10, 20 kgs. Tenofovir 300 mg tablet is advised in CLHIV who are more than 10 years of age and their weight band is more than 50 kgs. So according to the weight, you can see if the child is weighing less than 20 kgs, the preferred first regime is AL plus DTG. DTG in this is 10 mg disposable tablet. If the weight band is between 20 to 30 kg, again the recommended first line is AL, that is abacavir, lamivudine plus dolutegravir. But the dolutegravir in this is 50 mg once a day. And the patient who are more than 30 kgs and whose age is more than 10 years, the preferred regime is CLD, that is tenofovir, lamivudine, and dolutegravir. And always calculate the dose of AL-DTG 10 mg as per the pediatric dose chart, which you must be having in your centers or in your NACO catalogs. So this is the pediatric weight band chart. Everybody can see this is there in your guidelines. Okay, and this must be in your center also. What are the advantages of DTG 10 mg used in the children? Is first of all simplified dosage schedule, not a complicated one. The administration is easier because this tablet being disposable, so it can be dissolved in water easily. It's of better taste, better tolerance and lesser side effects. There is a faster viral load suppression, the high genetic barrier for resistance. There is evidence of superiority of DTG compared with ritonavir boosted lopinavir, harmonizes with the adult regime. So, what are the counseling messages for the caregiver and CLHIV you need to give? First of all, you need to explain for a lifelong ART and importance of the adherence and viral load suppression after starting the ART. Explain the benefits of BPG, its effectiveness, its safety, and it is easier to administer. Explain the rare side effects such as insomnia, fatigue and headache, rash, or report immediately. Explain about the weight gain due to DTG that may occur. Exercise and nutritional counseling to be done for the child. and the caregiver. Explain how to give the drugs. There should be 10 steps that you need to be followed. Their specific dosing is weight-based. Those will change as the child gains weight. So the DTD, so always remember वैक्सीन लैमेबुलिन जो भी आपको डोजिंग देनी है, प्लीज चाइल्ड के वेट बैंड के अकॉर्डिंग दीजिए, because बच्चे का वेट आफ्टर द DTG it might increase, so always look for the pediatric dosing chart before doing a prescription for a pediatric patient. Fixed timing of giving the drugs, you need to explain to the caregiver that DTG should be taken 2 hours before or 6 hours after taking a cation containing antacids or any uh, mm, antacid or laxative, any sulfate, any oral iron supplement, oral calcium supplement, or buffered medication. So, what do we do in the preparedness counseling of the DTG 10 mg base ART? You need to explain. There are 3 points you need to understand. You need to explain what BTG MG is a disposable and a sport tablet. That is, ये आराम से आपकी DTG 10 mg पानी में डिजोल्व भी हो जाएगी, आपको एक्सप्लेन करना है। और ये स्पोर्ट टैबलेट है, मतलब ये आसानी से 2 भाग में या 3 पार्ट्स में, 4 पार्ट्स में डिवाइड हो सकती है आराम से। Explain that the dose must be repeated if the child vomits within 30 minutes of taking the medications. Do you need to specify and when? लीजिए 10 mg कैन बी टेकन विद और विदाउट फूड। आप इसे खाने के साथ भी ले सकते हैं, खाने के बिना भी ले सकते हैं। डोज इज वंस अ डे एट अ फिक्स टाइम। Ensure that the timing is linked with the routine of the child. You can tell them they can put an alarm for that. Identify who is the primary caregiver. Usually the mother or father or grandparents or guardian are the caregivers. It is essential to identify a backup caregiver, secondary caregiver. So, what are the pre-ART activities you can do in your center? You can have a pill swallowing that you can give the first dose of the ART in your clinic or your center or the hospital, so that it will be easy for you also and parents also to understand how can we give the ART to the child. So, what is the important drug and drug interaction with BTG? So, when if a patient is on carbamazepine, you need to give BCG twice daily, or you can substitute with an alternative anticonvulsant agent. Somebody is on phenytoin or phenobarbital, you need to use an alternative anticonvulsant agent. And if somebody is on polyvalent cation products that contains aluminum, calcium, iron, magnesium, or zinc, that is antacid, simply digene or any syrup calcium, syrup iron, or any multivitamins or supplements, you need to use DDG 2 hours before और 6 hours after the polyvalent cation containing products. That is DDG आप उसको बोलोगे या तो उस जो भी वो सिरप ले रहा है उससे 2 घंटा पहले ले या 6 घंटे बाद में। If somebody is on rifampicin, that is on ATD, you need to use DDG twice daily. And if somebody is on amlodipine, you need to use an alternative antimalarial agent. So we'll summarize what are the ART options for a ART naive CLHIV. So if somebody comes you a confirmed HIV infection, that is either virological or serological testing, you need to treat and stabilize the acute condition, any opportunistic infection. You need to have a clinical evaluation, baseline CD4 testing, and other lab investigation. And you need to weight the child and age of the child. If the weight is more than less than 20 kgs, the preferred drug is ALDTG, that is abacavir, lamivudine plus dolutegravir 10 mg. The weight band is between 20 to 30 kgs. The preferred drug is abacavir, lamivudine, and dolutegravir. But dolutegravir in this is 50 mg. If the child is more than 10 years and the body weight is less than 30 kgs, that is between 20 to 30 kgs, you need to give same dose like ALD. If a child weighing is more than 30 kg and there is no renal disease, you can give the child, you can substitute or transition the child to TLD, or you can give TLD, I'm so sorry, in this ART naive patients. And if a patient is having a known renal disease, the preferred regime is avacavir, lamivudine, and dolutegravir. So let's do the prescription writing. Okay. You can see the drug dosing chart which is available. There was a 6-year-old child weighing 13 kg, a male child, having hemoglobin 8 gram per deciliter. The CD4 count is 500 cells. Anybody can do a prescription writing on the chat box? Anybody would like to give the answer? See in the chat box, Shweta?
Yes, ma'am. ALDTG 10 mg. There's one
Yeah, that's
response.
correct. Yeah, that's correct. But if somebody can tell me the dose also and more about the prescription in this.
Yeah, AL 60 by 30 mg.
Yeah. The guys are correct. So the prescription is will be AL plus DTG. AL will be 60/30, 2 tablet twice a day, DTG 10 mg, 2 tablet once a day. As the hemoglobin is 8 gram per deciliter, you need to provide maternate syrup also in this child. So will we, and the CD4 count is 500 cells, so we will not give CPT in this child. And its age is also more than 6 years old. Second question is, a child is 7-year-old, weight is 19 kgs, child is a female child, hemoglobin is around 9 grams, CD4 count is 300 cells, there are no opportunistic infection. What will you prescribe in this child? Any answers to this? Any answers to this in the chat box, Papa?
2 tablets daily, ma'am.
Okay. The answer will be
That must be for the earlier one.
the earlier one. So again, we'll give AL plus DDG 10 mg, and the dosing will be according to the weight band. The child is 19 kg, so we'll give 2.5 tablet twice a day. DDG also 2.5 tablets once a day. As the CD4 count is 300 cells, we'll give the tablet protramoxazole, single strength once a day. And hemoglobin is 9 gram per deciliter. We'll give the tablet folic acid and iron tablet once a day to the child. Now, there is a 3-year-old child whose weight is 9 kgs. The child is a male child. Hemoglobin is not available. The CD count is 400 cells. There are no opportunistic infections. So, what will you prescribe in this dog? Anybody can give me the answer. What will you prescribe in this child?
ALDTG 10 mg.
That is correct. You will provide the ALDTG.
Yeah,
And
AL
will you
60
give
by 30, 2.5 BD plus DTG 10 mg, 2.5 OD.
so in this? You will again give EL 60/30, that is 1.5 tablet twice a day, TTT 10 mg 1.5 tablet once a day. And as the child is 3 years of old, following in the criteria of advanced HIV disease, you will give the syrup ceftriaxone also, that is 5 ml once a day to the child. Now there is a 4.5-month-old infant who is diagnosed with HIV infection. The weight is 4 kg. There are no opportunistic infection. There are no CD4 available right now. What will you prescribe in this child? Anybody can answer me this? What will you give? Okay, this will ART paper is correct. You will prescribe the ALD 10 mg plus the Satram therapy for the child. So again, you'll give AL 60/30, 1 tablet twice a day, DTG 10 mg, zero point 0.5 tablet once a day, and you'll provide the syrup Ceftriaxone 2.5 ml once OD for the child. So now we'll come to the case scenario 2. That is, there is a child, Master B, who is 3 years of old, CLHIV, presented with the altered sensorium for the last 2 days. There's fog with fever for last 1 month. His father was recently detected to have a pulmonary tuberculosis. Mr. B was admitted in a hospital and diagnosed to have TB meningitis, that is TBM. He was started on anti-tubercular treatment 14 days ago. His body weight was 9 kg. The CD4 count is 14%. The hemoglobin is 9.8 gram per deciliter. So what are the questions? Will you give CPT in this child or not? The second question is, when should the ART be started in this child with TB-HIV co-infection? Anybody would like to answer that? Anybody would like to answer in this question? Is CPT indicated in this child? Any answers in the chat box, Shweta, for this question?
Ma'am, yeah,
Sorry.
no,
Actually,
4 weeks after
somebody,
anti-TB treatment,
yeah,
ART should be started.
yeah, that is totally correct. So, CPT is indicated in this child as the child is less than 5 years of age and the clinical stage is in 4. So, you'll give the syrup Septran 5 ml once a day, and this is a TBM infection. So, you will wait for 4 weeks after the ATT treatment. Then you will start the ART. ART to be started after completing 4 weeks of anti-treatment at least. Corticosteroid should be added adjuvant treatment for TB meningitis. So we'll continue with the case scenario two. When should the ART be started in a child with HIV TB co-infection? If any child comes you with the TB infection, timing, what are the timing of ART initiation in relation to the ATT treatment? So you need to initiate ATT first. ART should be started as soon as possible within 2 weeks of initiating TB treatment, regardless of CD4 cell count among people living with HIV, except when signs and symptoms of meningitis are present. So if there is a person, if there is a child living with HIV who comes out to be TB positive, and if there is a TBM, the ART should be delayed at least 4 weeks and initiated should be initiated within 8 weeks after ATT treatment for the TB meningitis initiated. And as we all know, for the TBM, the corticosteroid should be considered adjuvant treatment for the TB meningitis. So, main important criterion is, if some ART9 cell comes to you who is having TB, first you'll start the ATT. For any pulmonary TB, you can start within 2 weeks after the ATT initiation. But if there are signs and symptoms of meningitis or the child is having TBM, you will at least wait for 4 weeks and you will initiate within 8 weeks after the ATT. So we'll continue with the case scenario two. What should be the ART regime with the dose prescribed from him? Anybody can answer in this? What is the ART regime you'll give in this child? Yeah, that is correct. You will prescribe him. Plus, you will prescribe him abacavir lamivudine plus dolutegravir 10 mg, and you will prescribe him extra DTG 10 mg. That means you will give DTG twice in this child. So the dosage will be abacavir lamivudine 1.5 tab twice a day, DTG 10 mg tablet 1.5 tablet twice a day. So what are the first line ART regime in the child who is infected with TB? If the child is having weight less than 20 kgs, you need to give the same dose, the same ART, that is AL plus DTG, but the DTG 10 mg will be twice daily as per the guideline. As we know, does DTG does the drug interaction, the rifampicin does the drug interaction with the DTG, so you will give the DTG twice daily. When the weight is more than between the 20 and 30 kg, again the regime is AL plus DTG. DTG in this is 50 mg and it is twice a day daily again. If child is above 30 kg and age above 10 years, you will give TLD, that is tenofovir lamivudine dolutegravir. Plus, you will give the additional dose of DTG 50 mg after 12 hours. So, important note is that in this is DTG dose will need to remain twice daily for 2 weeks after the last dose of the sample. So after completing the ATT course, you need to give DTG dose for 14 days at least. In a drug-resistant TB cases, there is no requirement of changing the dose of DTG as there is no rifampicin in drug-resistant TB therapy. So what are the DTG dosing of the CLHIV with drug-sensitive TB? Everybody has this dosing chart. So in this, the DTG 10 mg becomes twice a daily. Okay, for 10 mg, and for the 50 mg, again it becomes twice daily. And if somebody is on PLD, that is tenofovir, lamivudine, and dolutegravir, we'll give an additional dose of DTG 50 mg to that child. Okay, and always remember, after completing the course of ATT, that is the last dose of rifampicin in a drug-sensitive TB, the DTG will need to remain twice daily for 2 weeks after the last dose of rifampicin. And if somebody is on drug-resistant TB, there is no need to change the dosage of DTG. So in the case scenario 3, there is a master C is a child living with HIV, age 8 years, presently asymptomatic. On examination, child is clinically stable. There are no opportunistic infections. Weight is 24 kg. The CD4 count is 386 cells. The hemoglobin is 12.6 gram per deciliter. Other investigations are also within normal limits. So, is the CPT indicated in this child? And what is the ART you will prescribe in this child? Anybody would like to answer the case scenario 3? Shweta, any answers in the chat box?
No, no, ma'am.
Okay.
ALD and I think CPT is not indicated.
That is correct. CPT is not indicated in this child as the child is in the clinical stage 1 as there are no cystic infections. The age is also more than 8 years and the CD4 count is 386. So we will not give CPT in this child. And the second answer is also correct. We will give this gene ALD. That is ALD 3 tablets in the morning, AL 3 tablets in the morning, 3 tablets in the evening, and dolutegravir 50 mg once a day. Yes. So case scenario 4. There is Mr. James D, who's 14 years of age, old, children living with HIV. He's asymptomatic. The clinical stage is 1. Weight is around 38 kg. The hemoglobin is 10 gram per deciliter. CD4 count is 458. The renal function tests are within normal limits. Other investigations are also within normal limits. So, is the CPT indicated in this child or not? What will you prescribe the child? So anybody would like to answer? Any answers, Shweta?
Ma'am, CPT is not indicated and
Yeah.
waiting for more answers. TLD.
This is also correct. CPD is not indicated as the child is more than 14 years. The clinical stage is stage 1 and the CD4 count is 458. CPD is not indicated and you will prescribe the drug PLG. As the renal functions are normal, the weight is 38 kgs and the child age is is around 14 years. So what are the frequently asked questions? Can we give DTG 10 mg, that is 3 tablets for CLHIV, weight around 21 to 29 kgs? So you need to note that disposable pediatric DTG is not bioequivalent with a film-coated DTG 50 mg. And there's a 30 mg of disposable DTG is equivalent to one film-coated 50 mg DTG. That means if the child is not able to have a 50 mg DTG, you can give 3 milligrams of disposable DTG. That is 3 tablets of DTG 10 mg. So use DTG 10 mg disposable tablet for children up to 19.9 kgs. And when the child reaches more than 20 kg weight back, need to use film-coated DTG 3 mg. And what are the options for the children who are more than 20 kg and not able to swallow the film-coated tablets? You can give the DTG 10 and 15 tablets either maybe into split into two halves, followed by the immediate ingestion of both halves of the tablet, or crushed and added to a small amount of semi-solid food or liquid, all of which should be consumed immediately, not to be kept. Or you can give DTG 10 mg small tablets given in dose of 30 mg, that is 3 tablets. So always remember 3 tablets of DTG 10 mg disposable tablet is equals to 1 film coated 50 mg THC. And what are other questions? Can DTG 10 mg be taken with food or milk? DTG can be taken with or without meals. So DTG 10 mg is disposable tablet. First of all, it should be ideally disposed in water. It can be taken with milk or food. It is a disposable tablet and should be disposed into a solution and given immediately, not to be kept. So there are educational videos in the YouTube or the NATO site, you can see it is both in English and Hindi. It is about 8 minutes. You can have the link also. So they'll describe you how will you give the DDD tablets to the child and what are the frequently asked questions in that. So next you can see I will explain you in English. So first you determine the dose. What is the dose you will give to the pediatric population for DDG 10 mg? First is to determine the dose. What is the dosing? How many DDG tablets you need to give to the child? The 10 mg disposable. Now you need to prepare the 10 DDG 10 mg mixture. How will you prepare it? If there are supposedly 1 or 3 tablets, you dissolve the DTG in 5 ml or 1 teaspoon of drinking water. When combining DTG 10 mg with Bacavir lamivudine or Cetirizine lamivudine tablets, you need to dissolve it in 20 ml or 4 teaspoons of drinking water. So always remember when there are 1 or 3 tablets, you need to dissolve the DTG in 5 ml or 1 teaspoon of drinking water. When you combine this DTG with other tablets like AM or ZL, you need to dissolve in 20 ml or 4 teaspoons of drinking water. Now, you will make sure the child drinks all the medications immediately or within 30 minutes of preparation. An important point to be noted, if any medicine remains in the glass or the bowl, add little water to the glass and bowl and ensure child takes the complete dose. So what are the benefits of disposable TTD and energy tablets? The dosing is very simplified. The administration is very easy. The DTG disposable tablets are action is the faster and there is a high genetic barrier for resistance. What are the reminders you need to give the caregivers? Let's remember DTG 10 mg should be given immediately or within 30 minutes of the mixing with water. And if the child vomits within 30 minutes of taking medications, give another full dose of DTG 10 mg. However, if the child vomits after 30 minutes, do not give an additional dose on the same day. If your child has any challenge in taking medications, or if you have any question, you can contact your ART center.
Thank you so much, ma'am,
आपको
for
उसको
facilitating.
prepare कर मैं audible now?
Yes, 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 you're audible, ma'am. Yeah, thank you
So
so
this is presentation is over. You can. So we need to have HIV-free generations. I hope from this RDLS session you might be आपको पता चल गया होगी how to give, what are the ART regime which are available for the children, how to give it, and any side effects, how to give it, and how do you need to prepare the caregiver for the ART. Any questions anybody would like to answer?
Ma'am,
Ask her.
yeah, we'll just give mic access. Yes, mic access has been given to all the participants. Please feel free to unmute, or you can also put your questions in the chat box. Kiran sir, I think you will have, yeah, that's done. Yeah. Any questions?
Any questions regarding ART regime for the children from CLHIV?
Good afternoon, ma'am.
Yes, ma'am.
Ma'am, I'm Dr. Handa. I'm from ART Center, Dehradun. I just wanted to know if
Yeah.
the child is weighing around 30 kgs and the child is on LPVR. I mean, he's not on the first line regimen. The child is on DTG
Oh,
LPVR. And since we run short on LPVR, what is the timing? I mean, to start
yeah.
ATVR, the child has to weigh
Hello.
35 kgs. Hello.
You're not audible, so actually your voice has been broke in between.
Ma'am, to start ATVR,
Yeah,
atazanavir, ritonavir, the weight has to be
yeah.
35 kgs in children.
Just give me a minute. I'll check from the weight band because I need to see the pediatric dosing chart for that. You're
Okay, ma'am.
saying that the child is on BTG plus LPVR on the second line, and you want to
Yes,
shift
ma'am.
the child on ATVR,
Yes, ma'am. Since we are running short on
short
LPVR.
of the LPVR.
Yeah, that's why I was
So, first of all, who do you send your referral or any kind of expert opinion like this into a center?
No, I'm not sent, ma'am, but I'm just asking you. I'm not sent, but then we
Because I
occasionally run
need to
short of it.
see. Yeah, yeah, I know
That's
the Lopenaver are shortage in the program, but I need to
fine.
have see the child viral load also. If it's
If
suppressed
the
or not.
viral load and all is normal, ma'am. If the viral load and all is normal.
Okay. So you
eh,
if you need to wait the child reaches 35 kg.
35 kgs.
Otherwise, you will have a pill burden and you'll because it will be difficulty for the caregiver also to give. If we give ATVR, because we have given in our center like ATVR in three-fourths of the tablet, but it is always a difficulty to give. If you
Okay,
give a child who is weighing less than 35 kg,
fine, ma'am.
issues, you can send a referral to us for the child.
ठीक है. Fine, ma'am. Thank you.
Okay.
Thank you.
Okay. Okay.
Any more questions? Please feel free to unmute. आप माइक अनम्यूट कर सकते हैं और सवाल पूछ सकते हैं या तो फिर चैट बॉक्स में भी अपना सवाल डाल सकते हैं. Ma'am, I don't think there are any questions. Thank you so much for facilitating this session.
Thank you so much, Shweta.
Thank you, ma'am. Thank you to all the participants for joining in and patient listening. We'll conclude the session now. Yeah. Requesting all the participants to please attempt the feedback poll. There are 5 questions. Please scroll through the questions and click on the answer of your choice. आपको 5 सवालों का जवाब देना है जो आपकी स्क्रीन पे अभी दिख रहे हैं. पांचों सवाल जो भी आपको सही आंसर लगता है उसको आप क्लिक कर सकते हैं स्क्रीन पे. Requesting all participants to please attempt the feedback poll. Before leaving the meeting, please attempt the feedback poll. सभी से रिक्वेस्ट है फीडबैक पोल अटेम्प्ट कीजिए. 5 सवाल है, आपको पांचों सवालों का आंसर देना है. जो भी आपको सही उत्तर लगे उस पे आपको क्लिक करना है. Kiran sir, we can end the feedback poll now. Thank you everyone.